This briefing provides a high-density summary of the 2023 Japanese Respiratory Society Guideline for Asthma COPD Overlap. We will focus on the key changes and their immediate implications for your clinical practice.
We'll proceed through 5 sections, starting with the most significant practice changes and then moving to the diagnostic algorithm, the new classification system, its associated pharmacotherapy, and finally, the management of exacerbations and comorbidities.
All right, let's begin with the most critical updates from the 2023 revision. The single most important change is the introduction of a new phenotype-driven classification system. This is a major shift. It directly links the patient's presentation to a specific pharmacotherapy algorithm, moving us away from a one-size-fits-all approach to a much more stratified, evidence-based strategy.
So this guideline really introduces 3 major shifts. First, we have a new phenotype classification system. This is based on asthma severity and symptom burden, which we measure using validated patient-reported outcomes. Second, there's an updated treatment algorithm that corresponds directly to this, with an inhaled corticosteroid-centric approach tailored to each specific phenotype. And third, we now have specific guidance on the role of advanced therapies, including biologic agents, for our patients with refractory disease.
Now, let's review the systematic diagnostic process for ACO. This is, of course, the prerequisite for applying the new therapeutic framework.
Here, you can see the complete diagnostic algorithm. Now, the mandatory entry criterion, the absolute starting point, is persistent airflow limitation. That's defined as a post-bronchodilator FEV1/FVC ratio of less than 70% in symptomatic patients who are 40 or older after you've excluded other relevant diagnoses.
An ACO diagnosis is confirmed by fulfilling criteria from both of these columns. For the COPD component, the patient needs at least one of 3 things: a significant smoking history, CT evidence of emphysema, or impaired diffusing capacity. For the asthma component, they need either 2 of the first 3 criteria, that's variable symptoms, asthma onset before age 40, or elevated FeNO, or one of those first 3 plus 2 or more features from the 4th category, which includes things like bronchodilator reversibility and blood eosinophilia.
These are the key quantitative thresholds that really anchor the diagnostic algorithm. Pay close attention to the specific cutoffs for type 2 inflammation markers: FeNO greater than 35 parts per billion and blood eosinophils greater than 300 cells per microliter. These values are absolutely critical, not just for diagnosis but also for subsequent therapeutic decisions, especially when we start considering biologic agents.
Okay, with the diagnosis established, we can now examine the new phenotype classification system, which is how we categorize patients for therapeutic planning.
This matrix is really the core of the new guideline. It stratifies patients into 6 distinct phenotypes, from type 1A all the way to type 4. You can see the vertical axis represents asthma severity, while the horizontal axis represents symptom burden, which is quantified by either the MMRC scale or the COPD assessment test. This framework allows for immediate, clinically applicable classification right at the bedside.
And this is the critical point: how this new classification directly dictates our therapeutic strategy.
This slide shows you the full pharmacotherapy table. The fundamental principle here, let's be clear, is that every single patient with ASOC requires an inhaled corticosteroid. We're going to break down the core recommendations for key patient groups now, based on their classified phenotype.
First, let's look at patients with a low symptom burden. These are your types 1A and 2A, classified based on MMRC scores of 0 to 1 or CAT scores below 10. For these patients, the initial recommendation is dual therapy. For type 1A, which is characterized by mild intermittent asthma features, the guideline recommends initiating a low-dose ICS plus either a LABA or a LAMA. For type 2A, which presents with mild persistent asthma features, the recommendation is a low to medium dose ICS plus a LABA.
Now, for patients who have a higher symptom burden, so that's an MR-MRC of 2 or greater, or a CAT score of 10 or greater, or for those with more severe underlying asthma, the guideline recommends we move immediately to initiate triple therapy. This table details the escalation strategy very clearly. For your symptomatic patients, types 1B and 2B, you'll initiate triple therapy with a low to medium dose ICS. For the more severe phenotypes, types 3 and 4, triple therapy with a medium to high dose ICS is now the standard of care. And I want to emphasize, the guideline strongly recommends using single inhaler triple therapy, or SIT,
to optimize treatment adherence.
What about patients who remain uncontrolled despite optimal inhaled therapy? Well, the guideline outlines a clear pathway for add-on treatments. You can consider things like leukotriene receptor antagonists, theophylline, and mucolytics. But critically, for type 4 patients with severe, uncontrolled disease and evidence of type 2 inflammation, biologic agents like anti-IL-5 or anti-IgE therapies are now indicated. Oral corticosteroids, as always, should be reserved as a last resort therapy.
Finally, let's address the management of acute exacerbations and the significant comorbidities that so frequently complicate the clinical course of ACOPD.
The management of an acute exacerbation follows a four-step process. First, assess the cause and inflammatory profile. Second, administer a short-acting beta agonist. Third, initiate systemic corticosteroids, but tailor the dosing to the predominant component. That means higher doses for an asthma-predominant exacerbation and a shorter course for a COPD-predominant one. And fourth, antibiotics are indicated only in the presence of purulent sputum, suggesting a bacterial etiology.
We must actively screen for and manage common comorbidities. Patients with ACO have a very high burden of cardiovascular disease, osteoporosis, and GERD. And of note, the risk for diabetes mellitus is actually higher in ACO than it is in either asthma or COPD alone, and that requires diligent metabolic surveillance on our part.
Remember, pharmacotherapy has to be paired with essential non-pharmacological interventions. Smoking cessation is absolutely mandatory. Combined influenza and pneumococcal vaccination is strongly recommended, and pulmonary rehabilitation is indicated to improve functional status and quality of life. And given the high exacerbation frequency and the potential for rapid decline in these patients, advanced care planning should be initiated early in the disease course.
So the critical takeaway from this 2023 JRS guideline is this: we must integrate this new phenotype classification to guide therapy. This structured approach is specifically designed to prevent both the undertreatment of the asthma component and the overtreatment of the COPD component, thereby optimizing patient outcomes. The implementation of this phenotype-driven approach is expected to significantly improve long-term outcomes and rationalize resource utilization in your clinical practice.